I will request Dr. Bhupesh to talk about his first talk, which will be interpretation of corneal imaging, especially the Scheimpflug camera and pentacam.
Good evening, all the attendees and respected chairpersons. So I'll be presenting my talk on interpretation of corneal imaging. I have no financial disclosures in any of the machines that I'll be talking about. So corneal topography is an essential component of refractive screening. And the main objective of doing corneal topography is to detect corneas with ectatic disorders and detect corneas at risk for ectasia. So in last 3-4 decades, we have seen various machines that are coming in practice, from OpScan to Pentacam to Galilei, Cirrus, and all have some or other advantage or some or other limitations. Although the true predecessor of topography is keratometers that we have all have practiced in our medical colleges or in our practice also, these Bosch and Lomb keratometers and Jewel Schwartz keratometers. But again, this is a primitive machine, and this also had some limitations, like it gives the values in 3 millimeter ring and just 4 data points, and it is totally operator dependent. So chances of getting something wrong is high. Then came the keratoscopy, and in the keratoscopy, the light is projected on the cornea and the rings are drawn. You can see in this picture the inferior steepening represented by the crowding of Myers. So if the Myers are very close to each other, that means there is a steepening, and if Myers are separated too much from each other, then that means there is a flat area. It also has some advantages, like it's simple, handy, low cost, and quick, although it has some disadvantages, like it is a qualitative test, there is no data point, it is subjective, and it also measures just a central cornea, and minor irregularities are also there. So then Elva Gulstrand start capturing the quantitative analysis of the captured image, and he formed the algorithms to obtain data on slope from the Placido disk images. Then came the video keratoscopy. Although this also had some limitations, like the data from peripheral cornea is unreliable. In this machine, the elevation data is not true, it's derived data. It does not apply to irregular corneas, and inability to image the posterior surface of the cornea is not possible with this machine. So coming to the current generation of topographers, it can be Placido projection-based topographers or elevation-based topographers. Projection-based topographers are not used nowadays. Everyone has shifted to elevation-based topographers. Again, in the elevation-based topography, it can be slit scan-based topography, Scheimpflug-based topography, or high-resolution ASOCTs. Like in slit scan, OpScan 1 and 2 are there. In Scheimpflug, Pentacam, Galilei, or Cirrus. In high-resolution ASOCT, Visante, Omni is there. Talking about OpScan combines two technologies. It has a calibrated video with a scanning slit beam system, along with advanced Placido disk system. So image acquisition is like this in OpScan. And if you talk about the data point which it measures around 9,600 data points. It is also non-invasive measurement of data points. And then based on these data points, it constructs mathematical representation of true topographical surface. So from derived, we have shifted to true surface. So this is very important concept to understand the best fit sphere. So for the cornea reference surface, typically a sphere is constructed by fitting the reference surface as close as possible to the data surface, and a best fit minimizes the square difference, always a positive number, between the two surfaces, but only within the spherical region that is known as best fit zone. So all the topography is based on this best fit zone. This is a very common photograph we all have seen. The reason for showing this photograph here is then that you can see all the plain areas in the world are shown by green, all the water bodies are shown by blue, and all the steep mountains are shown by red or maroon. So this similar concept has been used in corneal topography, which is again a color based. So this scale that is always there in all the scans from any machine. This scale is called Clay's-Wilson scale, and it ranges from 28 to 65.5 diopters. The interval between two colors is very important. It should be 1.5 diopters. If you reduce this interval, there will be a lot of colors on the topography, and anything to interpret is very difficult. So coming to the maps of topography, it can be a curvature map, elevation map, and pachymetry map. These are the very important maps to understand. So curvature map generates from the curvature data, that is Placido disk. It can be either axial or tangential. Again, it is represented by color-coded scales. So this is a chord map from OpScan. We are not using OpScan right now. In our college days, we used to study this. So in OpScan, what OpScan do, it divides the cornea in two zones, from 3 millimeter zone and 5 millimeter zone, and then you have to see the irregularity in these two zones. And if it is more than 1.5 in 3 millimeter zone and more than 2.5 in 5 millimeter zone, then those cases are suspicious. Again, in the bottom, we get the white to white diameters and thinnest pachy, AC depth, and angle kappa. So coming to the gold standard of color topography nowadays, that is Pentacam. So Pentacam is a rotating Scheimpflug camera which measures Scheimpflug images of the entire eye segment. In conventional cameras, the object, that is film plane, lens plane, and subject plane, all are parallel to each other. Whereas in Scheimpflug cameras, these planes are oriented at an angle to each other, and it intersects at a point called Scheimpflug line or intersection. The advantage of this system over conventional photography of the eye is that images along the optical axis of the eye can be assessed. And if we talk about the data point measures, it measures 25,000 data points, from 9,600 to shifted to 25,000 in Pentacam. The key advantage of rotating imaging process is it is precise measurement of central cornea. Correction of eye movement is possible with the machine. The fixation is very easy for the patient, and it's a very quick procedure, just take 2 to 3 seconds. So if we compare OpScan with the Pentacam, OpScan was less accurate in imaging anterior surface of the cornea. Pentacam is accurate. Poor accuracy in imaging the posterior surface of the cornea, or sometimes it's not possible also. Whereas in Pentacam, posterior cornea can be imaged very nicely. Inaccuracy in thin cornea was there in OpScan, whereas it's excellent accuracy in thin cornea in Pentacam. And it is a gold standard nowadays. So coming to the reading of maps. So how to proceed there? So it gives so many maps that which one to read, which one to not to look. So first of all, we have to look the anterior elevation first. After seeing the anterior elevation, then see the posterior elevation. After seeing these two elevation map, we have to go to pachymetry map and thickness distribution from center to periphery. If you find anything wrong in these three maps, try to correlate between posterior or anterior elevation with pachymetry map, whether the thinnest point of pachymetry is same with the elevation, then that will be suspicious cases. After these three, we have to look at the symmetry of both the eyes, how the distribution is there, if superior inferior symmetry is more or less, and if two eyes shows different superior inferior symmetry, then again it is a suspicious case. And we have to look at the curvature in the last. So this is a normal astigmatic cornea. So you can see the K readings is 42 and 46. Although there is the superior inferior symmetry is not there. So this is a normal cornea. So we get many patients with high astigmatism. They referred by the ophthalmologist to know that whether they have keratoconus or not because of high K reading or astigmatism. So if you get this kind of map, there is no superior inferior symmetry, then that is a normal cornea. Topography in keratoconus is the most important thing. So it gives many things, like I talked about anterior elevation, posterior elevation, pachymetry. So if you see this map, the pachymetry is 547 at this point, that is thinnest point. And at the same point, the elevation is maximum, 50. And at the same point, you can see elevation front, elevation back. So all four are correlating, then there is no doubt this is a confirmed case of keratoconus. This is another map of post-LASIK ectasia. So normally after LASIK surgery, there is a central flattening and peripheral steepening. But in case you can see there is central steepening shown by the red color and peripheral steepening shown by the blue color, just opposite the LASIK. So it confirms that ectasia is taking place. This is another case of post-LASIK ectasia. You can see central steepening with peripheral flattening. So this is the case after surgery. This is a case after LASIK, but there is no post-LASIK ectasia. There is a well-centered ablation, central flattening, and mid-peripheral steepening, which has to be there in post-operative LASIK patients. So after elevation maps, coming to the pachymetry map. Pachymetry map is the most important points are displayed in values and locations. So these give three important parameters: thickness in the pupil center, thickness in the apex, and thinnest location. The preoperative planning for corneal refractive surgery to know the pachymetry is very important, and for keratoconus detection and quantification, pachymetry is again important factor. So this is a global pachymetry map. You can see it's showing the pachymetry in different zone, and it is increasing from center to periphery. And this map is especially useful for if you're planning intacs, because if you plan to put the intacs in 6 millimeter or 7 millimeter zone, you know at what thickness you're going to put the intacs ring. So this global pachymetry map is especially for the intacs planning. Coming to the Bellin-Ambrosio enhanced ectasia display, this is a new feature in Pentacam. The original display Bellin-Ambrosio enhanced ectasia display software showed both anterior and posterior elevation data relative to standard best fit sphere calculated at a fixed optical zone of 8 millimeter. The second component of Bellin-Ambrosio enhanced ectasia display is comprehensive pachymetry evaluation. I'll be talking one by one. First is the corneal thickness map. So these two maps are the pachymetry progression map. First is the corneal thickness spatial profile, CTSP. So the first one, this graph represents the average progression of the corneal thickness from thinnest point to the corneal periphery. The graph is plotted using red dots, you can see here. And this red line should fall between these two black lines, at least up to 6 millimeter. If there is sudden change before 6 millimeter, then either biomechanics is poor, or it can be a case of post-LASIK ectasia, or something is wrong in the progression. Other thing is percentage thickness increase. There is PTI. This graph represents the percentage plot of above graph. Any sudden slope or rise within the 6 millimeter zone is again considered abnormal. So these are some of the values that are important. Average pachymetry progression index of less than 0.5 is normal, is less. If less than 1.2 is normal, and if it is more than 1.2, it is ectasia. And the shapes of the curves of thickness profile and percentage of thickness increase give additional information. Like see this map, just see the progression, this red line, which is going very in a normal track. There is no abnormal jump up or down. So this is a normal progression of pachymetry from center to periphery. And just see this cornea after LASIK surgery. You can see this also, central steepening. Other factor, at 4 millimeter only, it's going down the normal path. So it gives additional information in post-LASIK ectasia cases. And this is again a map of post-LASIK ectasia. You can see it is not following any track. If the progression map is haywire, then something is wrong with the pachymetry or the biomechanics. Coming to the last part, the new display report gives 5 differential parameters: change in anterior elevation from standard to enhanced reference surface, change in posterior elevation, corneal thickness at the thinnest point displacement, that means its distance from the pupil center. Further the thinnest point from pupil center, more chances of getting keratoconus. And then pachymetry progression. So each of these values is shown at the bottom of the BAD scan, Bellin-Ambrosio display scan report, giving the standard deviation from the normal population mean for that individual parameter. These numbers are color coded to turn yellow when it is more than 1.6 standard deviation, and red when it's more than 2.6 from the mean, and white when it is less than 1.6. So these values are important, and we should remember these values. The final parameter D represents an overall reading of all these 5 parameters, and it is calculated by regression analysis, which the software does. So these are the maps in the BAD scan. First is the elevation front and second is elevation back map. So how to interpret them? The standard elevation map, the first 2 elevation maps placed side by side display the baseline relative elevation of cornea of the best fit sphere. And second is the exclusion elevation map. In this map, both anterior and posterior of best fit sphere is calculated using all the raw elevation data located outside 4 millimeter. So first one is the center best in the best fit area zone, and second one is the outside 4 millimeter circle from the thinnest point of the cornea. The location of the exclusion zone is indicated by 4 millimeter circle, and you cannot change the circle position. So coming to the third or the most important part, that is difference elevation map, that you have to definitely look. If it is showing any red signal, then there is no for any surgery. So the bottom two maps are different maps. They show the relative change in elevation going from a standard to exclusion. The bottom maps are based on three colors, green, yellow and red again. So the green, if it is 6 micron on the front surface and 8 micron on the back surface of the cornea. The yellow, if it is 6 and 12 on the front and 8 and 20 on the back, then it is suspicious. And the red represent areas where elevation difference between the two maps is 12 micron anteriorly and 20 micron posteriorly. So this is a complete bad scan, and you can see this posterior elevation. There is a problem in the difference map, although the pachymetry progression is normal. You see this value is yellow, so it's a suspicious, but finally the D value is much in a normal range. So you can do surgery in this case. There is no problem. So again, a map of normal cornea, everything is normal, green. Both our difference maps are green, and again D value is less than 1.6. In this map, both the difference map showed yellow, so suspicious range, but this D value is 3.23, which is worse. So we should not touch these cases. So finally, these are some of the parameters that we should know, and if find any of these things, we should be suspicious and take action accordingly. Like if the Kmax is 48.7, the difference is more than 1 diopter, and in phase steepening of more than 1.5 diopters, superior steepening of more than 2.5 diopters, Q value of less than -1. Coming to the pachymetry map, if the CCT is less than 470 with normal topography, still you have to be suspicious. CCT less than 500 with abnormal topography, again you have to be suspicious. And then anterior elevation of more than 12 micron and posterior elevation of more than 15 micron. So these are the corneas at risk, so we have to be very suspicious and careful before planning any surgery. So in conclusion, interpretation should always be in conjunction with clinical scenario, and we should not try to misinterpret the colors. Thank you.